I'm old enough to have actually known Douglas Black, who was an extremely fine physician and an extremely compassionate man. I wouldn't say the same if I was in the Jenner room, who I think was in the 18th century. It's nice to think of being surrounded by people who did contribute a lot to medicine in a very compassionate way. I thought the most useful thing I could do, coming from an occupational health perspective, which is a perspective which arouses mixed feelings in healthcare professionals, it would be true to say, not always good ones, was to talk about how occupational health services, or an occupational health approach, if you like, could contribute to better health and well-being of healthcare workers. It is actually BMA policy that all NHS workers, at whatever stage, level, including general practitioners, do have access to occupational health services, but that's not true. They don't all have that, but it's something that BMA will be pushing, and will be pushing it hard this year at the annual regional meeting. Then, considering the audience, which is, I think, half and half doctors, I was going to talk a little bit about the specific problems of doctors. Occupational health professionals, in my kind of position, we see a lot of doctors for two reasons. Partly they refer themselves in very much the same way as they refer themselves to CARE's therapeutic service, the PHP, but also we get referred doctors by National Clinical Assessment Service, GMC, other trusts, doctors who are in trouble, and that may be trouble because of the way they behave, it might be, or it might be because they're not well. Usually it's because whoever is referring them wants a decision on whether this is predominantly a health problem or predominantly a behavioural performance problem. Usually they're all mixed up together. So we do an awful lot of sorting those kind of things out. And more doctors are referring themselves. And I think that's partly because they know that we do see a lot of people who are referred for this kind of problems. And so we're fairly used to using, we're fairly used to that sort of problem, analysing it, trying to sort it out. So, for those who perhaps don't realise what it's all about, occupational health is all about protecting workers from work-related hazards and diseases, and that includes psychological hazards, because quite a lot of what we're seeing now, what any occupational physician sees these days, is not asbestosis, it's stress. And so, complicated word, well, simple word, a lot of complications behind it, but that's what we see an awful lot of now, and try to do something about sorting it out. And in the context of work, whether this is actually work-related stress or work-induced stress, two different things, doesn't matter. It's often a question of working out the stressors, some of which are going to be at work, some are not going to be at work, they're going to be due to people's private lives, as it were. And there are reasons for having occupational health services. Interestingly, they're not statutory in the UK. You don't have to have them. You have to have something in really dangerous industries, kind of industries which might kill you, like a train railway service. On the other hand, you know, the National Health Service can kill you. So it's every bit as safety sensitive as you know, the nuclear industry, for example. And I can tell you, if you talk to people in the nuclear industry, they would have no argument that they needed occupational health services, partly to protect people against radiation, but also to make sure that people are psychologically well, shorthand for all sorts of things. So, you know, they're the wrong button. You know, I'll put it fairly crudely, because there's not much time. And, you know, healthcare workers have all sorts of hazards, quite a lot actually, compared with much industry in Britain now is sort of service industry, not heavy industry anymore. The main hazards are psychological. Do you know, healthcare is quite physical, nurses in particular. There are lots of chemicals used. There's a lot of viruses and infectious disease occurring. So there are hazards, and we mustn't forget them amongst all the stresses and strain type of hazards. And there are particular characteristics of the healthcare sector, and this is not just the UK. This problem is not just the problem of the UK. I give these kind of talks all over the world, and it's the same problems in the United States. There's the same problems in developing countries in Africa. So, and the same problems in China, completely and utterly different culture. So, this is something about the healthcare sector that is universal. And the characteristics, of course, it's labour-intensive. It's the most labour-intensive work that you can have. The staff are predominantly female in all countries, and we just passed now, I think, the 50-50 with doctors in Britain, that more than 50% qualifying are now female. Throughout the world, low pay, relatively, low status, and generally low self-esteem. And in some countries, doctors as well, low self-esteem. It's obviously psychologically stressful, it's becoming increasingly high-tech. As I said, it's physically demanding, and we're facing now worldwide shortage of trained medical staff, particularly nurses. So people are shifting all around the world to try and get jobs in other countries, pleasing developing countries on the whole and benefiting us. And there's a push towards, I'm sure people talk about this, 7-day, 24-hour work, which is going to bring in rotational shift work for healthcare staff, who not all of them are used to it. And it really is quite damaging to people's health, rotational shift work. I won't go on about how occupational health services can help in detail, but there is academic evidence, if you like, that you can control infection better within the hospital anyway. I know we're not only talking about hospitals, but you get a better educated workforce. Our workforce at St Thomas's, I think, is very well educated about health and well-being. It promotes trust and confidentiality between the management of hospitals and the staff of hospitals. There's no time to talk about that in detail, but it does improve trust and confidentiality. It improves sickness absence. It actually helps to attract and retain staff. And perhaps most importantly, I think you had Jill Maven talking at one of your sessions. It is proven now, I think, to improve the level and quality of patient care. If you very obvious, but if you have healthy and happy staff, they're going to provide better care to patients. Claire talked about now that there's a grassroots movement here, actually trying to confront or to address the powers that be in the NHS. We did actually try to do this before, and it's quite interesting to reflect why it wasn't that successful. In 2008, I chaired a group for the Department of Health on just this subject. We had lots of high-profile people on it. Carol Black was on it, Steve Borman was on it. And we had a series of meetings with Claire Chapman, who was then the head of HR for the NHS, or the Department of Health. And came to a number of conclusions, one of which was there should be a proper scientific look at this. We got somebody independent to do it, who was Steve Gorman, who was a distinguished physician who looked after the Occupational Health Post Office at the time. And he produced the Gorman Review in 2009, I think, which some of you will have seen and read. It's full of common sense, it's pretty well evidence-based. It clearly stated that the health and well-being and happiness of NHS staff was good, needed to be approved, and it gave a series of recommendations about how it could be done. And this was taken up by the Department of Health. And I think there was a flurry of activity there, and a lot of interest in it, which has almost completely died down again. So I think this initiative now, which is approaching it in a rather different way perhaps, is good, because I think it needs to be kept on the agenda, and it needs to be escalated now. You've actually got the head of the NHS now, who, amusingly enough, used to be my junior administrator, Alan Stevens, who is well aware of all this stuff. I mean, he's perhaps constrained by what he can say, and perhaps constrained by the work he's done since he left the civilised job he had when he was here. But he listens, he's sensible, and so I think there's some inroad there. Now, I was going to talk very briefly about doctors, because, as I said at the beginning, they're a particular group. They have particular problems, and I guess their health has been rather neglected. And there's been lots of studies on doctors. They're undoubtedly more distressed, generally speaking, than the rest of the equivalent professional population. They might just be interesting for you to know the kind of things that one would see as an occupational physician. Doctors presenting themselves. Now, I have this on a PowerPoint. I realised that that was not the ethos that you want to.
David, we're coming up to the hour reaching cycle.
I'll give you a very short sort of idea of what sort of things one might see. And I presented this at the BMA conference last year on physician health. And this was about doctors at all levels, at all stages of their training, or all stages of their careers. So, medical student, or aspiring medical student, can I train as a doctor? I've got cystic fibrosis. I've had a lung and pancreas transplant. So I'll give you the answers to these. The doctor in training. I can't cope with shift work. I'm tired all the time. Consult an obstetrician. I find I can't remember things. You know, am I developing Alzheimer's disease? A consultant physician. Being treated for a brain tumour. Is it about time I retired? And what are doctors actually referred for? What sort of things? Okay, finally, a medical student with anorexia nervosa. Can she be registered as a doctor? Newly appointed consultant oncologist admitted to the A&E department with a respiratory arrest due to a mixture of alcohol and blood drugs. Junior doctor found to be using hospital lab to test his own blood specimens. He'd been taking anabolic steroids and was checking his biochemistry. Consultant physician writing a balmy letter to the chief executive. Chief executive said, what am I going to do with this? As you know, people write things down that they don't actually say. These are just some examples. And what should one's response to that be? I tell you it's not unique treatment. It's an analysis of the problem. It's a functional assessment of what's actually wrong. It's not about disease, generally. And it's an attempt to match that up with what that doctor, doesn't need to be a doctor, because it's the same process everywhere. It's a risk assessment and an analysis, or a piece of signposting usually, as to what that doctor can do about it. Very few of these actually need medical intervention. They need listening to, understanding the context of what they're doing work-wise, and then working with them to come to some sort of resolution. We do tend to medicalise these things. I send very few people to psychiatrists. When I do, it's usually people who are really ill. I'll probably leave it there because I just wanted to give a little bit of an overview of what an occupational health service can do. And after all, there are occupational health services in most hospitals, not in general practice, that's a contentious matter. So they're there, not all good, but they're there, so they are a resource which can be used. Sometimes they're a setup which is utilisable. So,
Thank you so much. Lovely, I'll hand you over to Cindy.